In clinical practice, contraception is defined under the broader framework of family planning. It is the application of specific physiological techniques to avoid unintended pregnancy and allow individuals to achieve their desired parity at the optimal time. Our analysis of these mechanisms is grounded in the foundational text by Dr. Vivilis and Dr. Bontis. The theoretical benchmark for an ideal contraceptive is strict. It must be 100% effective, completely devoid of clinical complications, and easily accessible at a low cost. To date, this perfect pharmacological profile has not been engineered. This chart shows the CDC's 2014 Contraceptive Efficacy Scale, built using life table analysis. This statistical method calculates failure rates by tracking the exact number of pregnancies that occur per 100 women during their first year of applying a specific method. Evaluating these methods requires splitting the data into two distinct categories. Theoretical effectiveness represents the protection offered when a method is used perfectly, adhering strictly to all clinical guidelines. Typical effectiveness measures outcomes in reality, accounting for missed doses, incorrect application, and irregular schedules. The divergence between these two numbers is the compliance gap. Human behavior drives failure rates upward. The more a contraceptive method relies on daily user intervention and memory, the wider this gap becomes. Moving from the bottom to the top of this chart, we progress from the least to the most effective clinical options. This hierarchy serves as our structural roadmap. Each tier corresponds to a different physiological intervention point in the reproductive cycle, starting with physical barriers against gamete collision, advancing to localized chemical toxicity, and peaking at the absolute suppression of the neuroendocrine axis. Navigating clinical counseling requires understanding this efficacy gap. The data consistently demonstrates that the most successful contraceptive methods are those designed to bypass human error entirely, removing daily memory from the equation. At the base of the efficacy hierarchy are physical methods. Coitus interruptus, or withdrawal, yields a high typical failure rate. Even with timely execution, spermatozoa are frequently present in the pre-ejaculatory fluid that enters the reproductive tract prior to climax. The rhythm method attempts to avoid conception by calculating the biological fertile window. This relies on mapping the days surrounding ovulation, operating on the physiological baseline that an ovum is viable for up to 48 hours, and spermatozoa can survive in the reproductive tract for up to 60 hours. Identifying this window requires tracking specific physiological markers. Patients must monitor daily changes in cervical mucus viscosity, test urine for the luteinizing hormone peak, and continuously record basal body temperature. This graph shows the correlation between ovulation and basal body temperature. Immediately following ovulation, the release of progesterone triggers a distinct thermal shift, raising the body's basal temperature by 0.2 to 0.4 degrees Celsius. Moving to chemical interventions, spermicides utilize targeted agents like nonoxynol 9 or octoxinol. These are applied directly to the vaginal vault prior to intercourse. These compounds function through direct cytotoxicity. They induce rapid immobilization and structural destruction of the spermatozoa before the cells can navigate through the cervical os. Barrier methods, including male and female condoms and cervical diaphragms, operate on a mechanical principle. They physically obstruct the trajectory of the spermatozoa, preventing the gametes from ever colliding. These physical and chemical tiers exhibit typical failure rates ranging from 24 to 28%. Yet, barrier methods, specifically condoms, retain absolute clinical necessity, as they provide the only mechanical defense against the transmission of sexually transmitted infections. Ascending to the intermediate tier introduces long-acting reversible contraceptives, primarily the intrauterine device, or IUD. Here, the typical failure rate drops precipitously to 0.8%. The device is physically deployed directly into the endometrial cavity, completely bypassing the gastrointestinal tract and systemic circulation. Copper IUDs release ions that generate a localized cytotoxic inflammatory response. This highly toxic microenvironment severely inhibits sperm motility and destroys their fertilizing capacity. This diagram shows the secondary abortifacient mechanism of the device. The continual inflammatory reaction renders the endometrial lining inhospitable, preventing a fertilized ovum from successfully attaching and implanting. Progestin-releasing variants add an endocrine component to this local action. The continuous diffusion of progestogen induces profound thickening of the cervical mucus, creating a secondary physical barrier against sperm penetration. The localized nature of the IUD carries specific clinical risks. Insertion can cause acute pain and hemorrhage, and the presence of the device increases the risk of severe pelvic inflammatory disease if a pre-existing cervical infection is present. If an unplanned pregnancy occurs with an IUD in situ, the clinical protocol demands careful management. The presence of the device inherently carries a 50% risk of spontaneous abortion, and typically the device is surgically removed to terminate the gestation. The statistical superiority of the IUD over barrier methods is derived entirely from its deployment. Its set-and-forget design systematically removes daily human compliance from the efficacy equation.
The combined oral contraceptive is the most widely utilized pharmacological method globally. Each dose delivers a precise combination of an estrogen and a synthetic progestogen. Unlike the localized disruption of an IUD, the primary systemic goal of oral contraceptives is the absolute pharmacological inhibition of ovulation. This chart contrasts natural cyclical hormone surges with a pill-managed cycle. Notice the sharp, natural peaks on the left. On the right, synthetic steroids use negative feedback to suppress the hypothalamus, blocking FSH and LH secretion to maintain flat profiles. If ovulation suppression fails, secondary hormonal effects act as physiological failsafes. The progestogen thickens the cervical mucus to block sperm motility and simultaneously halts endometrial mitosis, leaving the tissue too atrophied to support implantation. Alternative delivery systems like transdermal patches and vaginal rings utilize the exact same mechanism of action. By absorbing hormones directly through the skin or mucosa, they successfully bypass first-pass metabolic degradation in the liver. Altering systemic endocrinology carries risks. Hepatic induction of angiotensin can trigger hypertension in some patients. More critically, synthetic estrogens exerts a hypercoagulable effect on blood factors, elevating the baseline risk for thromboembolic disease. Clinical guidelines specifically caution against prescribing combined oral contraceptives to smokers over the age of 35. In this demographic, the compounding cardiovascular variables begin to outweigh the contraceptive benefits. For patients with estrogen contraindications, the progestogen-only pill provides an alternative. Rather than guaranteeing absolute ovulation suppression, this formulation leans heavily on its secondary mechanisms, sustaining hostile cervical mucus and a thinned endometrium. Beyond preventing pregnancy, the systemic regulation provided by oral contraceptives offers measurable secondary benefits. They stabilize erratic menstrual cycles, mitigate dysmenorrhea, and provide a demonstrated protective effect against both ovarian and endometrial carcinomas. Post-coital intervention exists as emergency contraception. Administering a high-dose progestogen, like levonorgestrel, within 72 hours of exposure, attempts to trigger the premature degradation of the corpus luteum and disrupt the endometrial environment before a blastocyst can embed. Hormonal contraception demonstrates that a total, calibrated pharmacological override of the neuroendocrine axis produces a theoretical efficacy approaching 99%. The peak of the clinical hierarchy is surgical sterilization. By severing the physical conduits of reproduction, failure rates drop as low as 0.15%. The objective is permanent structural disruption. Gametes are still produced, but the anatomical pathways required for their transport and union are completely blocked. In females, tuboligation mechanically blocks the fallopian tubes. The conduit is sealed using suture ligation, localized cauterization, or by excising a targeted segment entirely. In males, a vasectomy performs the equivalent disruption by severing and sealing the vasa deferentia, ensuring ejaculate is completely devoid of spermatozoa. While advanced microsurgery provides a theoretical avenue for reversal, standard clinical practice dictates that sterilization must be treated and consented to as a permanent, irreversible procedure. This permanence makes surgical sterilization the most prevalent method in developing nations. It requires a single intervention, completely eliminating the need for long-term supply chains or daily medical maintenance. Because the procedure is anatomically localized, it lacks the systemic endocrine side effects of hormonal pills, and the surgical complication rate remains exceptionally low. By physically dismantling the infrastructure of fertilization,
surgical intervention is the only contraceptive category where typical, real-world efficacy and theoretical perfection effectively converge. Reviewing the hierarchy reveals a stark clinical reality. As interventions scale from localized physical barriers to systemic hormonal suppression, and finally to irreversible surgical alteration, the compliance gap steadily collapses. The clinician's responsibility is to navigate this matrix alongside the patient. High efficacy must continually be weighed against an individual's physiological tolerances, specifically evaluating distinct risks for thrombosis, hypertension, and pelvic inflammation. This diagram illustrates the next phase of delivery systems. Subcutaneous microchips are being designed to automate the release of progestogen over a span of years. Concurrently, pharmacological trials are utilizing testosterone to successfully suppress male spermatogenesis. Research is also expanding into multi-target applications. Newly developed vaginal rings integrate hormonal suppression with specialized antiviral agents, aiming to merge high-tier contraceptive efficacy with active defense against HIV and other sexually transmitted infections. Immunological approaches are attempting to weaponize the body's own defenses. Experimental vaccines are engineered to induce targeted antibody production against endogenous gonadotropins, or the proteins of the blastocyst itself. An intervention that is perfectly effective, entirely harmless, and completely passive has not yet been engineered. But by advancing long-acting reversible contraceptives and investing in male-focused pharmacology, modern medicine is aggressively closing the behavioral gap.